Hello.
Hey William, how you doing?
All right. How are you?
I am good.
Can you hear me all right?
Yep, you're sounding great.
Looks like we have a captioner here already. Anthony, thank you for being here with us.
Hello, thank you.
I am going to share my PowerPoint. Anybody want to take a gamble on whether I do this correctly?
I'll give you a 50-50.
So one says desktop 2, and the other where I see it says PowerPoint. I wonder which one I select.
I usually do desktop just so it shares the whole screen. But that being said, it also shares the whole screen. So if there's anything you don't want shared on that, then it's not as good. Okay, that looks good. The only problem with doing that is now if you get a notification or something, it'll also show up.
Oh, it will?
Yeah, if you share the whole screen, anything that appears will show up rather than just PowerPoint.
So like if I get text messages, it'll start showing up there?
Yep.
Oh, I don't want to do that.
Yeah.
Okay, so I don't want to do that. All right, let's try again.
There you go. That looks good.
I wouldn't have known the difference though.
Yeah, it's just, it kind of depends on what you want to do. So for this, just PowerPoint's fine, but in a different setting, you might want to share additional windows and not have to restart a screen share every time you switch to programs.
So if I wanted to put, I have a second screen.
Mm-hmm.
If I wanted to switch them just because I wanted them, the ones with the script on it on my bigger one,
Mm-hmm.
how do I do that?
You should just have to click swap screen, I would think. And then
How did that work? Do you still,
now we see the presenter view, but
yeah.
if you restart the share now, there might be two PowerPoint windows and you can pick the main slides.
Okay.
Or maybe not.
Mm-mm.
Yeah, that's odd. This should work.
Let me try one other thing. Which one are you seeing now?
The wrong one.
How about now?
That looks good.
Good, I did it.
Good job.
Okay. Okay. Terry, are you there?
I am here.
Awesome. So for those of you who have signed on early, you're in the right place for today's webinar entitled Building on Your Experience with Evidence-Based Hearing Practices for Children Birth to 5. We're going to be starting at the top of the hour in about 15 minutes. So you can just get your volume adjusted to your liking now, and we'll get started at the top of the hour. Mary, if you have a moment to check your email, I'd love your input on what I sent. For those of you who have just signed on, you're in the right place for today's webinar, building on your experience with evidence-based hearing screening practices for children birth to 5 years of age. We're going to start at the top of the hour. That's in about 10 minutes from now. So for now, just get yourself comfortable and your volume adjusted to your liking. You notice that there is a live transcript option on your screen. That's a way to activate the captioning for today's presentation, if that would be a benefit to you. We have people signing in at a fairly rapid pace right now, so we're going to be patient as people sign on here. And we had over 1,300 people register for this webinar from all across the country. So we are delighted at that response. Today's webinar is going to allow you an opportunity to type in some questions when we get to the point in our webinar where we will be responding to those questions. So we invite you to hold tight for now. Given the large numbers of people that we have on here, we hope that we'll be able to handle all of the questions that come in, but I think we're able to anticipate a lot of the issues that you wanted to get us to respond to. And for those of you who submitted questions in advance, we've been able to incorporate a lot of that information into today's webinar. We are just getting started. We haven't started quite yet. This webinar is being recorded, and that means that it will be available for you to review or to share with others in the next couple of days, and it'll be available on infanthearing.org. So know that you'll be able to share this information at another after our webinar is over. But again, for right now, if you wouldn't mind holding your questions, we don't have the bandwidth to respond to everybody right now. So unless you have a technical issue, and please, if that's the case, then by all means, let us know. And our technical person who's on will be able to assist you with that. We're going to start here shortly. Notice that there is a live transcript option on your screen, which will allow you to look at captioning if that is helpful to you during today's presentation. So you can click on that if that is of use to you. And then you can adjust the proportion of things as they get displayed on your screen. Terry, can I do a sound check with you?
Yes. Hi, 1, 2, 3. This is Terry. Thank you, William.
Sounds good. Thank you. As I mentioned a moment ago, we have people signing on at a very rapid pace right now, and we had well over 1,300 people register for today. So I'm going to hold off just a minute to get started so that everybody has a chance to shift gears from whatever they were doing up until this moment, get settled in, adjust their volumes, and take a deep breath. We sure appreciate everybody who has registered for today's webinar and hope that we can provide some useful information. As I mentioned a moment ago, today's webinar is being recorded. And what that means is that on infanthearing.org, you'll be able to go and review today's webinar again, share it with others who weren't able to attend live with us today. So if anything distracts you or takes your attention away during today's webinar, never fear, you'll be able to view this again and give us a couple days to get it posted, and then it'll be up there. Infanthearing.org is where that will be. I'm going to continue to just speak for a bit so that everybody has a chance to adjust their volumes while they get settled in. I'm going to give it 2 more minutes and then we'll get started. As I mentioned a moment ago, we are going to open up the floor for questions twice during today's webinar. And so we ask you to hold your questions until we do that. I'm hoping we can anticipate some of your questions and thereby forego the need for you to type it in. For those of you who submitted some questions in advance, we appreciate that and have attempted to build in answers to those questions in our presentation. But if there's something we didn't address or something that comes up for you during today's conversation, you'll be able to do it at that time. So I think we should get started and honor everybody who's here on time. I'm Will Eiserman, and I am the Associate Director of the National Center for Hearing Assessment and Management and the Director of the Early Childhood Hearing Outreach Initiative, also known as the ECHO Initiative at Utah State University. Before I go any further, I just want to cover a few of the logistics for today. Today's webinar, for those of you who have just signed on, is being recorded. So that means that in the next couple of days, it will be available for you to review again or to share with people who aren't attending live on our website, infanthearing.org. So jot that down, and you'll know that you can go there. And if something takes your attention away during today's webinar, never fear, you'll be able to review it again in a couple of days. At the end of today's webinar, you'll have an opportunity to give us an evaluation feedback very quickly that will also generate a certificate of attendance for today's webinar. So if that is important to you, be sure to not sign off too early, because at the end, that link to that survey and certificate generator will appear for you to use. And we will be opening up the floor twice today during for typed in questions that we will then respond to. So hold your questions until we invite them, if you would, so that we can be as efficient as possible, and hopefully we'll address your question before you even have to ask it. So I'm going to turn off my video so that you can focus your attention on the slides. They're much prettier to look at than I am. And so let me do that, and then I will proceed. So as I said, my name is Will Eiserman, and I'm the director of the ECHO Initiative at Utah State University, which is housed in the National Center for Hearing Assessment and Management. NCHAM currently serves as the Early Hearing Detection and Intervention National Technical Resource Center, which is funded through a cooperative agreement with Maternal and Child Health Bureau. Starting in 2001, for about 20 years, the ECHO Initiative served as a national resource center on early hearing detection, with a focus on supporting early Head Start and Head Start staff in implementing evidence-based hearing screening and follow-up practices. And we are delighted to be able to continue to make our resources and other learning opportunities like this one available to staff in Head Start programs, as well as to anyone from other early care and education settings who can put these resources and these learning opportunities to use. Now, I'm joined today by Dr. Terry Faust, who is a pediatric audiologist and a speech language pathologist, who we have been lucky enough to have as our consultant and standby trainer and good friend of the ECHO Initiative since our very beginning. So Terry, say a few words for us.
Thank you, William. I appreciate that. It's been a real privilege to be associated and be part of the ECHO program. And as William said, he and I, along with other ECHO team staff, as well as many local collaborators, have provided training in nearly every state. And it's amazing to think that it's really involved thousands of staff from early Head Start, American Indian, Alaska Native, and Migrant Head Start, and many other early care and education programs over the years, we are always encouraged, as we are today, by the huge amount of interest that there is in establishing evidence-based hearing screening programs so that children with hearing-related needs can be identified and served.
Today's webinar is primarily intended for those of you who already have some experience implementing evidence-based hearing screening for children, either in the birth to 3 age range, the 3 to 5 age range, or both. We're delighted that we have well over 1,300 people registered for today's webinar, and many of you have submitted questions in advance, and our responses to which have we've tried to incorporate into what we have planned for you today. We should have ample time to take additional questions if others come up during our presentation. So if something comes up while we're chatting, jot a note, and if we don't answer your question, then you can share it with us when we invite you to do so. We also noticed that some of you are folks that are new to doing evidence-based hearing screening. And if that's you, by all means, we welcome you to stay throughout today's webinar. But we also want to alert you to the fact that on February 9th, we are having an introductory webinar that will present the topic of evidence-based hearing screening for children throughout the birth to 5 age range, starting at the very beginning. So you'll see the link here for registering for this webinar. We'll put it in the chat as well. Gunnar, if you can do that, that would be great. And we invite you to come to that instead or in addition to today's webinar, and by all means share it with other people who you think would benefit from this. If you do have introductory questions, that's the webinar where we will be focused on those. So today we're going to organize our time around many of the questions you all submitted. We will present some information about each of these topics. After each topic, we will check in with you to see if you have any additional questions before we move on. We're going to start with a brief review for our newcomers to evidence-based hearing screening on the purpose of hearing screening and what the recommended methods are. We will then turn our attention to a review of issues pertaining to using pure tone audiometry and to questions submitted by those of you who are screening children 3 to 5 years of age with that method. Since many of you are getting involved with doing screenings for a bulk of children this spring, we'll go over some of the key steps you want to complete to prepare for this. We'll then review the steps of the procedure and address the questions you raised about pure tone screening. After we address any questions you have about pure tone screening, we'll then address otoacoustic emissions or OAE screening. Since many of you are also doing this screening, we're going to overview the steps one more time as you prepare to do a group of children. We'll then review the procedure, offer some helpful hints for screening, and then we'll delve into your questions about children who may be challenging to screen and other issues that you've raised. That will be your next opportunity to ask some additional questions if you have any. Next, we'll talk about the follow-up protocol, which relates to everyone, regardless which screening method you use. It's the same recommended protocol, by the way, for those of you for when a child doesn't pass a screening, regardless of which method you're using. We'll address the follow-up steps and the questions you raised about how to communicate with parents about screening results, how to appropriately encourage follow-up action, and how to address interfaces with healthcare providers. We're going to wrap up by reviewing resources we have online to help you further and address many questions that you have. I'm going to have this sidebar appear throughout the session today to help remind you of the topic areas that we are talking on at that moment, so that you can target your questions to be addressed at the right moment. So let's get started. You've likely seen this graphic before. We like to remind people that the work of the ECHO Initiative is based on the recognition that each day young children who are deaf or hard of hearing are being served in early childhood education and healthcare settings, often without their hearing-related needs being known. Hearing loss is an invisible condition. So how can we reliably identify which children have normal hearing and which may not?
Well, William, the short answer to that question is that early care and education providers can be trained to conduct evidence-based hearing screening, which you see depicted here in these photos. The ultimate outcome of a hearing screening program is that we can identify children who are deaf or hard of hearing who have not been identified previously. So you'll recognize the procedure on the left as being otoacoustic emissions, or OAE hearing screening. And that's the recommended method for children birth to 3 years of age, and increasingly recommended for children 3 to 5 years of age as well. Now on the right, you'll see the procedure pure tone audiometry hearing screening. And that's historically been the most commonly used screening method for children 3 years of age and older. And you'll still see it in many early care and education settings and providers using that. Now, as William said, we'll be talking about both of these methods today, keeping in mind that the hearing screening process does not diagnose a hearing loss, but it does identify children who need further follow-up, either by a healthcare provider or an audiologist, with that ultimate aim of diagnosing a hearing loss, if in fact that exists, and then connecting these children to the intervention services that they need. So your screening process is the first important step in that process.
Some of you have asked whether you need to be certified to do screenings. That tends to be a state-specific issue. We don't know of any states that require that, but there are some state guidelines that can influence your practices. So we always encourage you to check that out. A good way to do that is by contacting your state's newborn hearing screening office, or what's called the Early Hearing Detection and Intervention Coordinator, also known by acronym as the EHDI or EDI coordinator. We have a link to those offices on our website, which I'll be showing in just a bit. Now, some of you have also asked about how you can more effectively encourage parents to follow up when a child hasn't passed a screening. One way is to share information about the incidence of hearing loss and the fact that a child's hearing can change at any time, often without us even recognizing it. About 3 children in 1,000 are born with a hearing loss, deaf or hard of hearing. Most newborns in the US are now screened for hearing loss using evidence-based methods, most before even leaving the hospital. But screening at the newborn period isn't enough. The research suggests that the incidence of permanent hearing loss doubles between birth and school age, from 3 in 1,000 at birth to about 6 in 1,000 by the time children enter school.
So we really can't only screen for hearing loss at birth. We need to screen throughout early childhood, because hearing loss can occur at any time as the result of illness, physical trauma, or environmental or genetic factors. This is often referred to as late onset hearing loss, simply meaning that it's acquired after the newborn period. And again, similar to the subtle changes that can occur in vision, in any of us, a child can also experience a change in hearing ability that we want to identify. We want to identify it so they have full access to language and all of the information that they are exposed to as they learn and grow.
And so that information is really helpful to share with parents if you're trying to encourage them to do follow-up.
Yeah, so again, screening is simply that first step in the process of identifying a disability such as a hearing loss. And since no screening method is 100% effective in identifying possible areas of concern, parent or caregiver concerns always overrides a passing screening result, no matter what screening method is used.
Any conversation we have about screening and follow-up should always begin with a reminder that hearing screening methods aren't perfect, and that whenever a parent or a caregiver expresses a concern about language or hearing, children should be referred for a more thorough evaluation, even if, as Terry said, the child passed the hearing screening. And that is true even with the highly reliable hearing screening methods we're talking about today.
Yes, and it's also important for us to acknowledge right up front that for any number of reasons, there will be an occasional child that you just simply can't manage to screen. After you've tried everything you can do and you've had a colleague try as well if possible, you'll be faced with that dilemma of what to do. You just will get that hard to complete screening child once in a while. So here's our recommendation about that question, which some of you raised. If you aren't successful screening a child, refer that child to someone who can. Often that will be a pediatric audiologist. Keep in mind that sometimes the children you may have difficulty screening are actually the very ones who have a hearing loss. So we really don't want to skip them and just try next year.
So we just mentioned having a pediatric audiologist in the picture. A pediatric audiologist, if you don't know, is a person who specializes in the diagnosis and non-medical treatment of hearing-related and other disorders associated with the ear and the auditory system. A pediatric audiologist specializes in children. So having access to a local pediatric audiologist can really be helpful. We recommend that all programs consult with a local audiologist to help develop and oversee your hearing screening and follow-up activities. They can help you with equipment questions you might have, consult with you about specific children who aren't passing your screenings, and importantly, maybe one of your resources when you need to refer a child for further evaluation, or one of those children that are difficult to screen, as Terry was just mentioning. Now, on our website, kidshearing.org, you'll find the link for Find an Audiologist, which should help you.
Now, some of you submitted some really great but very specific questions about the error messages on your particular equipment. And while I acknowledge that it's important to get answers to that, that's difficult for us to address in a group setting remotely like this. And so we recommend that you pose those questions, those specific questions about error messages on your equipment, to your the person who sold you that equipment. While equipment distributors and salespeople are not who you should look to for the comprehensive training you need to develop your screening program, they can absolutely help you understand your equipment's functions, its error messages, and things like that. So having access to both a pediatric audiologist and your sales rep can be really helpful for different reasons. So we encourage you to have their contact information ready for when you need it. And sometimes the equipment manual is really helpful as well.
And when we're talking about error messages, we're pretty much referring to OAE equipment, of which there are a number of different brands and models. And that's why we can't get into the nitty gritty. But one thing to keep in mind is that most of those error messages are responded to in the same way, and that is try again. And we'll be talking about all of the steps you want to check before you try again. But those error messages aren't quite as different in their actual meaning as they seem to suggest they are. Now, Terry, while we're on the topic, some people submitted questions about screening children with PE tubes. So let's just answer that question right now.
Yes, yeah, that's great. So, yes, you can absolutely and should screen children whom you know have PE tubes. It's actually one way to find out if those tubes are doing the job that they've been put in to do. So, children with PE tubes should pass hearing screenings if the rest of their auditory system is functioning normally. So, for those of you that are using the OAE screening method, you'll want to look at your equipment manual just to make sure if you have to do an extra button push to adjust the setting for screening an ear that has PE tubes. Most do not need that adjustment, but there are a couple pieces that do. So be sure to check that out. Some equipment, as I said, just requires a temporary adjustment while the other brands do not. But yes, you can and should screen children with PE tubes.
Okay, so we have two screening methods that we want to talk about today. By way of big picture, if you're responsible for children who are under 3 years of age, the recommended method is OAE screening, which you see on the left here. And if you're responsible for screening children 3 years of age or older, historically, pure tone audiometry has been considered the recommended method for that age group. This is the headset screening where the child raises a hand or performs another task each time they hear a sound that's presented into the earphone. You see this method here on the right.
Several of you have asked about why some programs that you're aware of are no longer using pure tone audiometry with that 3 to 5 year old population, and you've seen them switch to OAEs. And I think that's because there's a growing recognition that although the pure tone method has been the most widely used method historically, it may not always be the most feasible method to use with some of these younger children. The research has shown that about 20 to 25% of children in that 3 to 5 age group can't be screened with this methodology because they aren't developmentally able to follow the directions reliably. And that's really been our experience as well. And in those instances, then, OAE screening is the preferred method for those children. And as we emphasized a moment ago, we want to be sure to screen every child, even the ones that we find challenging to screen, right?
So at a minimum, if you're establishing evidence-based screening practices for 3 to 5 year olds, and if you're considering using the pure tone screening method, you'll also need to be equipped and prepared to do OAEs on that 20 to 25% who can't be screened with pure tones. Or alternatively, you'll need to have a means for systematically referring all of those children to audiologists who can perform the screening, which frankly can be a bit challenging in its own right if you're referring 20% of your children to an audiologist for a screening.
Yeah, so I think just to simplify things, in summary, more and more audiologists are recommending the use of OAEs uniformly with all children 3 years of age and older. It's quicker than pure tone screening, both to learn to do and to actually implement. And it's far more likely to be a method that will work across the board with all the children in that 3 to 5 age group that you'd be screening. And it's equally as effective.
If you or your program are still undecided or are grappling again with the question of which method to use primarily for children in that 3 years of age and older group, we encourage you to carefully review a document that we have on our website that compares OAE screening and the pure tone screening method for this population. Now, here's an important note. Some states, some of you have asked about regulations. Some states have regulations about what methods are to be used based on age, requiring pure tone for children 3 years and older. at least as the primary method. So you need to check with your state if you're considering OAEs for the 3 to 5 age group. And you can do that by contacting your state's newborn hearing screening program that I mentioned before. You'll find the link to that state office on our website. And on another note, we had a question about whether there are any other recommended evidence-based methods that should be considered. So Terry, what's your response to that?
Currently, these two procedures or screening procedures that we've talked about, these methods, otoacoustic emission screening and pure tone audiometry screening, are still the recommended methods to be used for hearing screening. So the short answer is no, there aren't any other recommended evidence-based methods that should be considered for these age groups. Okay, now let's jump into our first screening method and review it. So let's look at pure tone audiometry screening. To conduct pure tone screening, we are first going to take a look at the ear, the outer ear, to make sure that there's no visible sign of infection or blockage. And by the way, you'll always want to do this first, regardless of which method you use. And then if the ear appears normal, then you as the screener are going to instruct or condition the child how to listen for a tone and then respond by raising a hand or placing a toy in a bucket. Once you've seen or observed that the child reliably responds to the sounds that are being presented, just as you instructed, and you see that response, then the actual screening is started. During the screening process, this listen and respond game is repeated at least twice at 3 different pitches on each ear. And we note the child's response or lack of response after each tone is presented. If the child responds appropriately and consistently to the range of tones presented to each ear, then the child passes the screening. During the screening process, this listen and respond game is repeated at least twice, again at 3 different pitches on each ear, noting the child's response or lack of response after each tone is presented. And then if the child responds appropriately and consistently to the range of tones presented to each ear, then the child passes the screening.
We want to remind you of some of the things you'll want to be able to be sure to address as you get ready to start screening a group of children. To begin with, and this goes for everyone, regardless of which method you're using, be sure to refresh yourself on the resources that are available on our website, kidshearing.org. This is the landing page for kidshearing.org, where you'll find a range of resources including general information if you're needing to acquaint new staff or refresh yourself. So we'll just go through this page for a minute and see what we have here. We have big picture resources, getting the introductory information covered. You'll see there where to find an audiologist right underneath the big picture resources, and then information about screening equipment. Then we have information about accessing training, where you can go to get online training for either of those methods. In the next category of resources, there's a variety of things for preparing to screen, checklists for how to get ready for a day of screening, that I think is useful if it's been a few days since you've screened the last time. The protocol guide is there. We'll be talking about the protocol in a bit here. Forms you can download and use, and resources for sharing the results with parents, healthcare providers, or audiologists. And then last, our tracking tool and tools for monitoring your program's quality. So be sure to review those periodically and make sure you're putting what you can use to best use. As you prepare for a round of screenings, here's the checklist for pure tone screening that you'd want to work through. You'll want to go through each of these steps. There are a lot of steps to pure tone screening, so you really want to make sure you are following these steps exactly. For those of you who only do OAE screening, you can really sympathize with people who are doing pure tone screening because it's not an automated process. The screeners have to step through the functionality of their equipment manually. So in getting ready, you'll want to prepare a quiet environment. You'll want to really look at the sound level and do a sound level check on your room. Most smartphones have apps you can download a sound meter from to check the decibel level. You'll look for the documentation forms, the screening toys that you need, and any universal precautions that you want to have in place from a hygiene perspective. You'll want to get your equipment out and the seating arranged for the child so that they can't see the screener's hands directly, and to also be sure that there are no reflective surfaces in the room that might inadvertently cue the child on when they are to respond. That's a really important one. You'll want to look at the condition of your cords, the jacks and the headphones, and make sure that it's all intact. And you'll want to clean those headphones and then do a listening check on yourself to make sure that the headphones are working as you would anticipate they are. And you'll want to do that before each screening session for the day, not before each child, but at the beginning of a round of screening. You'll want to look at your self-listening check. You'll want to look at the tone type and make sure it's set to either the pulse, warble, or frequency modulated, and that you have the tones presented to the right ear first, and then the left ear. And then you'll want to set the tone type to a steady state, tone presented continuously to the right ear, while chords are moved or manipulated to check to see if there's a sound break or a crackle or distortions based on the condition of those chords. And you want to do that for both ears. So have a look at this pure tone screening checklist and work through each of those items as you do your screening. Terry, we've pointed out that the conditioning process in pure tone screening is essential. Some people on today's webinar have asked how long the conditioning process should take as a part of the total screening. Can you comment on that?
Yes. So children who are going to be successfully screened using the pure tone method, they ought to be able to be screened in about 10 to 15 minutes maximum. So that conditioning should not take much more than 5 minutes, even hopefully less. If you can't condition a child in that amount of time, then you probably should consider using your backup plan, which is either to do an OAE, hopefully, right then while you have the child there. You could also try on another day if you have the flexibility to do that. Just remember that if you can't screen the child, then we'll need to do an OAE or refer the child to someone who will be able to successfully screen the child. And most likely that would be a pediatric audiologist. Now, as we said earlier, remember that some children who have hearing loss could be the very ones that are the most difficult to condition to do the screening. So one way or another, we want to be sure that we get every child screened. Now, once the child is conditioned, you want to start the actual screening process. And during the screening process, as we mentioned, this listen and respond game is repeated, and it's repeated at least twice at 3 different pitches on each ear. And we note the child's response or the lack of the response after each tone is presented. If the child responds appropriately and consistently to that range of tones that's presented to each ear, then the child passes the hearing screening. And it really is critical, as William mentioned, that you follow these steps exactly. And we recommend always starting with the right ear, just to avoid confusion for yourself if that becomes a habit. The goal of the screening process is to test the child's hearing at 3 pitches or frequencies. And those are 2,000, 4,000, and 1,000 hertz. And we screen them in that order. The volume level during the screening must be set and needs to remain at the 20 dB level. That's the screening level for all the tone presentations. You'll screen the right ear first and then the left. And again, in order for each to obtain a pass result for each frequency, the child needs to indicate the correct response at least 2 times. And we don't want to give the child more than 4 tries to get it right. In order for the child to pass the screening overall, they need to get a pass on every pitch on both ears. So if this is unclear or if you need a refresher, then we really encourage you to seek some additional training and to practice with this, because it's critical that we all understand it. The training resources that William mentioned, that are linked to on kidshearing.org, they will also go into detail on all of this. So what you see here on your screen is an example of the actual screening steps that need to be documented for each ear as you screen. And again, based on these results, the screener determines if each ear passes or not. The device itself won't produce that result, as is the case with OAE screening. And then we always want to be sure that we document the results as we go, just as you see here. Our screening form permits you to do just that.
Now, this is the screening form you'll find on our website that you can just download and use if you want. It takes you step by step through all of the processes of the pure tone screening that Terry just outlined, helping you follow these steps exactly. You'll notice that the form also includes the rules for obtaining passing results over on the right. So if you don't remember the rules, just look at the form. Terry, one of the questions from our participants was, what if a child does fine in responding at first, but then becomes distracted, or you observe is no longer engaged in the screening, say after the first couple of pitches? What do you do?
Yes, sure, that can happen. So you want to document as far as you got, and then you can do one of several things. You can go ahead and use your backup method if you have OAEs instead, or you can come back to this child on another day and continue where you left off. Just making sure, however, that you always start by repeating the conditioning process. We want to make sure they understand that the best that they can before you continue with the actual screening steps where you left off.
And you have to do the same thing if there was a sudden increase in, say, environmental noise that is outside of your control too, right, Terry? If you can't continue to screen at that time, you've got to come back at another time, picking up where you left off.
Yes, absolutely.
If a child completes the screening and meets the pass criteria, you're done for that child. If they don't pass, then you'll be referring to the follow-up protocol that we'll be going over in a moment, and which incidentally, again, is identical for both pure tone and OAE methods. All right, let's pause for a moment and see if those of you who are using the pure tone method have any other questions specifically about the use of the pure tone method. Preparing to screen, conditioning, conducting the actual screening, documenting the results. Do we have any questions about pure tone screening that we can address here? And if not, we'll proceed and talk about OAE screening. So the first question is, can you go back to retest the pure tone? I'm not exactly sure what that means. Terry, do you?
Yeah, thank you. I'm wondering about this in two ways. One is if you were not feeling confident in your results and you wanted to go back and retest, absolutely, go back and retest. If you weren't confident in the child's conditioned response, for example, you can go back and retest. And then also, as we just mentioned, that if you got reliable responses, say at one pitch, and then perhaps the lawnmower started and you weren't in a conducive environment anymore, then you might come back and retest. So yes, you can retest.
Great, thanks, Terry. The next question is, I've been trained in my district to screen at 25 decibels. Is 20 decibels or 20 dB the standard we should be using?
20 dB is the consistent standard, and it's recommended by the American Academy of Audiology as well as the American Speech Language Association. We know that on occasion that some guidelines have been adjusted in the past because of noise levels, perhaps in certain rooms, and we always want to be careful with that. But I guess the bottom line answer is that 20 dB is the benchmark standard.
The next question is, can you explain why the order is 2,000, then 4,000, then 1,000?
Sure, because in most cases, the child will condition easier to 2,000 hertz. And the real quick answer is that most hearing loss will be high frequency or may affect 4,000 first. So if they had a hearing loss, we want to screen in a frequency where they're most likely to hear and not have, so that we can get the test. But the bottom line answer is it's the frequency that they are most likely to successfully condition at versus the other two.
Great, thanks, Terry. So coming back to the individual who asked the question about 25 dB versus 20, what does that mean then? If we are screening at 25 dB, is that considered not passing? What do we do about that?
If we stay with the benchmark levels of 20 dB, then a 25 would not be a pass. And I would probably see if there's a review, and they could do a literature review and reassess what those passing levels are for your particular program.
The next question is also related to that. What about screening at the 25 dB level at 500 hertz?
500 hertz is not necessarily it's not included in most screening protocols. And so, as you can see on our form here, we screen at 1, 2, and 4. Some programs have included 500 hertz. It's a more difficult level to screen because the noise, ambient noise in the background, often referred to as the noise floor, often has energy concentrated around 500 hertz. And so, but the recommended protocols don't include it. I know that some programs have added it.
So the next question is, would you attempt pure tone screening first before OAEs on 3 to 5 year olds, or just do one or the other?
It depends on what equipment you do have, and so if you have only pure tone screening, of course you'll do that. If you have OAEs, but your children are seem developmentally appropriate and well functioning, you can do your pure tone screening and have the OAE as a backup.
So are you saying that they have to raise their hand twice for each frequency to pass at each frequency?
What we're saying is we need a good, reliable response paired with the presentation of the stimulation, and that needs to be reliable at least twice to pass.
Yeah. So right here, you see the rules for each frequency, and they need to have 2 passes, 2 right, raising their hand twice out of a total of 4 attempts. Once they've done it twice, you can move on. Like in that lower right hand 1,000 hertz, you see that they responded to the first 2 attempts, and so they didn't need to keep trying at that one, at that level. But yes, that's the correct protocol. And this is one of the challenges of doing this screening is, going through all of these repeated attempts to validate a child's response. If you're unclear about this, I would encourage you at the end, we'll show you again where our training resources are that go into this in much greater detail. So this is what implementing evidence-based practice is all about. And we appreciate the challenges that this represents, and maybe that sinking feeling if you haven't been doing it quite correctly as you learn, but you're learning. And this is an important step in that process. The next, and I think the final question for this, and then we're going to move on, is what about screening at 25 when you've got background noise? We screen high school students in bulk at their prep day, and there's often a lot of background noise. So do you change the level, Terry, when you've got background noise?
Yeah, thank you. There's a lot of emerging research on the effects of slight to mild moderate hearing loss. The reason that the American Academy of Audiology and the American Speech Language Association is screening at those levels is they do want to screen for those low levels of hearing loss. And then that adds objectivity into it when we just decide, to raise our levels without, measurements of what that background noise is, et cetera. And I know this is a difficult conversation, or it makes things a little bit harder because it's hard to control those screening environments. But those are the recommended levels. And so I'd encourage your programs to maybe, rediscuss those and make those decisions according to your program and your health advisory committees, and with input.
It's really important here for us to circle back at our goal. And our goal is not to pass children. Our goal is to have them screened as rigorously as we can, so that those who might have a permanent hearing loss can be referred to an audiologist to have it fully evaluated. So you're having children that don't pass is not a bad thing. It's a helpful thing. So having a rigorous standard is the goal. I know that we've been in some workshops where we've had people say to us, I know how to pass every child. I just turn the volume up. That's not the goal. And so keep that in mind. We want children to succeed. But in this case, we want to just know how they're hearing. And we don't want to influence that outcome. Now, one final question for you to remark on, Terry. We've got a colleague of ours from the UK who works in Uganda, of all places, who says that the World Health Organization has recently recommended 30 dB as the pass threshold. And Terry, what do you make of that contradiction between the standards that are being recommended here within the American Academy of Audiology and the American Speech Language Hearing Association, and what our friend is telling us about the World Health Organization?
I think even as we've just seen within programs here and with the questions today, that there's variability. Some of that variability has to do with the availability of various pieces of equipment, those that are trained, a lot of factors. So, and those, they look at worldwide standards there, and there's going to be some variability, but I can tell you that 30 dB will miss the slight to mild hearing losses that occur between 20 and 30. One reason it's important to note that too is because we get a child on a regular monitoring schedule, so that if that slight to mild hearing loss is progressive, we'll be watching it and watching for it. So, I do know there's some differing standards, but that's the bottom line for us, is that we want to catch kids that may be at risk.
It all comes down to, what are you screening for? And if you only wanted to screen for children who were severe to profound, profoundly deaf, you would screen differently. But we're not really screening only for those cases. We want to screen for mild hearing loss as well. And we have the ability to respond to those identifications in this country to be able to support children with mild hearing loss. So back to our website. This is where you'll find some resources related to pure tone screening. We encourage you to take a look and get acquainted with these, particularly the training resources that are available under Pure Tone audiometry screening. So check that out, as well as these others that we talked about before. There's a checklist for screening skills that go over all of these steps that we've just been talking about, which you'll find on the website as well. So take a look at that and make sure you're following all of those. Because this is not an automated process, this checklist is really good to check yourself on. Maybe have an observer watch some of the screenings to make sure that you're sticking to this checklist. And it's a great evaluation and retraining refresher tool as well. All right, let's shift our attention over to OAE screening. As we've already said, this is the recommended evidence-based method for children birth to 3 years of age. Terry, walk us through this process quickly here, if you can.
Yeah, so to conduct an OAE screening, we first are going to take, just like we did before, a thorough look at the outer part of the ear, again, to make sure that there's no visible sign of infection or blockage. And then if the ear appears to be normal and healthy, then a small probe on which a disposable cover has been placed is then inserted firmly into the ear canal. And then there's a button on your equipment that's pushed to start the automated screening process. Now the probe that sits, it sits independently in the ear. That probe delivers a low volume sound stimulus to the ear. And a cochlea, or the inner snail-shaped portion of the ear that you see here, a cochlea that is functioning normally will respond to this sound by sending a signal to the brain, while also producing an acoustic emission. And this emission is analyzed by the screening unit. And in approximately 30 seconds or so, a result appears, and it appears either as a pass or a refer. And every normal, healthy inner ear produces an emission that can be recorded in this way.
So as you prepare to do OAE screening, you'll find resources related to that, just as you do for Pure Tone screening on our website. So again, just take a look at what we have available there. Again, access to training and all of the other kinds of resources are available there. There's also a checklist for OAE screening, so you can work through those. If you haven't had your equipment calibrated in the last year or so, you'll want to make sure you do that to make sure it's working properly. Regardless of what screening method you'll be using, you want to make sure you communicate with parents and other program staff whose cooperation you're seeking.
Some of you have also asked about how to prepare children for hearing screening. And our main recommendation is to just keep it as fun as you can, regardless of which method you're using. And rather than referring to the activity as screening or a hearing test, call it a listening game. And you can engage teachers or parents in some activities that include noticing the child's body parts like their ears, and then maybe expand on the idea of what animals have ears as well.
We have a little listen up song, in fact, on our website that you can find there that basically, is used with the slightly older children to get them excited about the day they get to have their ears screened and played with. So take a look at that. This is, again, where you'll find all those resources. I just keep pointing out, go here. We have lots of things that programs have shared with us that you're able to download and just use for free. So before you create something, check it out here to see if it doesn't already exist. Under the screening resources, you'll find that checklist for getting ready to screen. You'll find a handout for parents about screening in English and Spanish, a handout for parents, a handout for teachers, a letter that you can send to healthcare providers about what you're doing. And that's where you'll also find that listen up song that I just mentioned. Like many skillful tasks, competent screeners can make it look easy. And we know that's the case. But no matter how much experience you have, I know that you've had challenges. We all have. A number of you have submitted questions about children you struggle to screen for various reasons. So let's talk for a minute about some of those strategies. Let's start by taking a good look at these pictures right here. These children you see here are all being screened using the OAE method. What do you notice about where they're being screened? They're not being pulled out into a foreign environment that might be frightening or unusual to them. They're being screened in everyday educational and home environments where they're already happily spending time. And those doing the screening are people they know. They're teachers, they're home visitors, they're health specialists. That right there is a really important part of having success. In fact, the screening works the best when children are familiar and comfortable with the adult who's doing the screening, where they can play with a toy, be held, or even sleep while the screening is conducted. So we have lots of options. Now, some equipment is more efficient than others when attempting to screen in these various natural environments, but most of them can work just fine under these conditions. Now, there are several keys to successful screening to keep in mind. Terry, you want to go over these 4 keys of screening?
Yeah, thank you, William. I apologize. I've been freezing up here just a little bit. But the 4 keys to successful screening are here. It's good probe fit. We want to minimize movement. And we want to minimize internal noise and minimize external noise in the environment. Now, the goal with proper placement is that you have a really snug fit. You want to seal out all of the noise from the environment. And that means you need to select as large a possible probe cover so that when you insert the probe into the child's ear, you can totally let go of it and it will stay in place. In fact, you have to let go because if you hold on to it, your touch can loosen it, allowing more noise to get in and disrupt the screening process. So as you select probe covers, always aim for the biggest one that will fit in the child's ear canal. That's There's no great secret aside from experience in being able to make a good probe cover selection.
Because some brands of OAE equipment have a compressible foam probe cover, which tends to be the easiest to achieve success with. So if foam covers are an option, you'll want to try those, especially if you're having trouble with getting that good snug fit that allows you to let go.
Let me interject, William, a little aside about probe covers. You can only use the probe covers that are intended for your device. Even though you may see others on the market, you can only use those made for your brand of equipment. They're made specifically and calibrated for those. And if you don't, you'll get inaccurate results.
Now, some of you have expressed a concern that you're worried that you could hurt a child by inserting the probe.
We understand that concern, but I want to assure everybody that these probe lengths have been carefully designed so that you don't do that, so that it's not possible. Now, a child with an active ear infection may experience pain with the probe insertion, putting that probe in, but it's one of the reasons why we want to carefully inspect the ear prior to doing a screening. But otherwise, probes will not go in deeply enough to harm the child's ear.
So you'll find videos on our website that review exactly how to do this. So you might want to look at that again and make sure that you insert the probe and you are able to always let go.
That's right. You always let go and it should stay put. And you also want to make sure that the cord has been clipped to the child's clothing, so the weight of the cord doesn't pull the probe out of the ear. Those are two essentials for getting and keeping a good probe fit.
Of course, as you screen, there will be times when you get an error message, as we referred to before, an error message or a refer. And as I said, don't worry too much about what the error message says, because regardless, you're going to do the same things and then try again. You're going to reposition the probe. You're going to reduce external noise. You're going to check the probe for wax and cleaning it or replacing it with a new cover. You're going to quiet and reduce the movement of the child. And you're going to use a unique quiet toy to distract the child. So don't get too disturbed about what the error message is. Just repeat the process. And you can always elicit the help of somebody else if you're still not having success.
So we've received a number of questions asking for suggestions on how to screen children who are just challenging to sit still or for whom you just can't seem to complete a screening. We'll go over some strategies, and then if you have some additional questions, we can take them. There are several strategies that will help make it a positive experience for the children and for you. And those are that we want to create a fun feeling around that screening activity. So position the child, yourself and other helpers in a way that's comfortable, and then allows the child's behavior to be naturally directed. Use toys, distractors, and other rewards effectively, and then document the screening results accurately. Now let's look at each of these for a moment. In creating a fun feeling, and William, my slides are slow to advance, so let me know if I'm jumping ahead.
Yeah.
Okay. So in creating a fun feeling around the screening, that involves establishing rapport with the children. For example, you may tell a child you're going to play a listening game and include another adult as the first person to be screened, placing the probe near their ear and asking them if they can hear the birdie sing. Or if you're working with a group of children, ask the teacher for suggestions about which child might be the most cooperative and should be screened first in order to set a good example and a tone for the other children to follow. I just want to say here that in our experience, this is what I really think you are all great at. We can teach technical skills, but that natural ability you all have to work well with children is really something I've admired when we've worked with many of you.
Now, when eliciting children's cooperation, you still want to tell them what you're going to do rather than ask if they want to participate. That is really very important. Don't give them the opportunity to say no. You direct the screening. You may even suggest to the other children that they have to wait their turn, just like they would with any other fun activity. So set it up as a fun activity and that they get to participate and be next. We want to use terms that describe the activity as fun and interesting, avoiding phrases like test your ears or saying something like it won't hurt or won't be painful, because you're likely to get a response that you don't want if you actually bring up some of those kinds of words. You want to position yourself to the side of or slightly behind the child, which gives good access to the ears to facilitate probe insertion. So you may want to sit on the floor at the child's level. So really think strategically about how you're going to position that child. You want to have toys and distractors available, and it's really good to have toys that the child hasn't ever seen before or only rarely, so that you can really capture their interest and present those toys strategically right when you need them to be the quietest and the stillest. Sometimes you can distract them by just touching them gently on their forehead or on the back of their hand. That'll redirect their attention from their ear to this other thing that you're doing with them. Introducing something that captures their attention through another sense can distract them just long enough so that you can get the screening done.
You can also consider playing a child's song on a portable music device by presenting the earbud to the ear not being screened.
Yeah, that's another strategy. Now, once you're complete, you want to reward the children with praise, no matter if they passed or not. And it can be really helpful to screen in teams where one adult is managing the child while the other is focused on completing the screening. So, offering choices. You don't want to offer the child a choice of whether to be screened or not, but you can offer a choice about what toy they want to play with or where they want to be screened. You can familiarize the child with the probe, because sometimes there's a little resistance, especially if they've had some prior ear infections and pain in their ear. Have them touch the probe. You can gently rub it on their face so that they know that it's soft. You might want to even simulate the screening on a doll or a stuffed animal to just get them comfortable with that. Now, sometimes the child will cry when the probe is inserted. You don't have to automatically remove the probe when a child cries, even though that may be your impulse. Instead, you can let the child relax with the probe still in the ear and have your finger close to the start button, ready to start the moment the child is silent. Sometimes you complete the screening from that moment, even if the child continues to be a little fussy. A child can cry on and off sometimes, and the screening may even proceed as long as the probe is still in the ear. Terry, what about oral distractors? What do you think about those? Oh, I'll jump in here. If a child is uneasy about being screened, they can be soothed with a pacifier or even a snack, and you can attempt to screen while the child is sucking or chewing. This does, however, introduce noise. So if you get a refer when you're using one of those oral distractors, you need to rescreen that child again without the sucking or chewing going on before you can have confidence in that refer result. Another strategy you might consider is screening in groups. This can help some children who may be fearful about screening get comfortable with the process, as long as they're seeing others having a positive experience. So you want to start with a child that you or the teacher is fairly confident will be cooperative and set an example that you're hoping for, that it's a pleasant enough process. So if you can create that moment, that can create your efficiency. Now, sometimes children who have been treated repeatedly for ear infections or other conditions may be reluctant to being screened. And those are the children that you want to either spend some time getting comfortable with, or maybe have them screened while they're sleeping. In fact, you don't have to have a reason to screen them while they're asleep. That can just be a great strategy for screening, especially some of the littlest ones that you're screening. Remember that if you do not get a passing result, as long as the child is cooperative, you want to try the ear again right then and there, making sure that you get a good probe fit and a minimized internal and external noise. Of course, it's very important that once the screening is complete, you're sure to document the results completely and accurately. Now, in documenting the results, you want to make sure that if you have an ear that does not pass, you're sure to accurately indicate which ear did not pass. And as you'll see in a moment, these forms that we have available for you to use directly correspond with the recommended follow-up protocol, helping you know exactly what the next step is in the process when a child doesn't pass, until the child screening and perhaps the evaluations after the screening are completed. So we've had some questions about screening children who have autism and other developmental delays. Terry, are you with us?
Hey, William, this is Gunnar. Looks like Terry's having some internet issues, so I'm working with him to get him back in.
Okay, great. I had a feeling that may have occurred. So one of the questions we got earlier was about whether there are any other methods that are recommended for children with autism. And as with all children, really the OAE method is the best method that you can go with. And if you can't screen a child with autism successfully with OAEs, then you would want to refer that child to an audiologist. Remember, a child with autism can have a hearing loss also, and that would be really helpful to know. In some rare instances, there are children who have been identified with autism who actually didn't have autism but had a severe hearing loss. So you want to make sure those children have the benefits of a quality screening, and if you can't do that, to make a referral for a complete audiological evaluation. Now, as you screen children, think about how to arrange the environment to support your screening. You'll want to have some toys available, other manipulatives, and that can really help. So our best screening efforts are only worthwhile if we implement effective follow-up. So let's take a quick look at the follow-up protocol to make sure you understand this, and if you have any questions about that. And then we'll open up for our last round of questions about OAE screening and the protocol. Now, one of the good things to remember is that the steps of the protocol are the same regardless of which screening method you're using, pure tone or OAEs. So this protocol applies to both. There's one main rule to remember. The screening and follow-up process is complete when either the child passes the screening on both ears, or the child receives an evaluation from an audiologist and you've gotten the results. Anything else is a child who is in the process of being screened or followed. So let's walk through the screening protocol. The screening and follow-up protocol and the accompanying forms are all available on our website. So I'm going to just move through this quickly, and then you can go through the tutorial and you can look through these documents really carefully if you're still unclear about this. So we screen the ear, and if the ear passes, then the process is complete for that ear. If the ear doesn't pass after several attempts, remember, we're going to try it again during the same initial screening session, we're not exactly sure why. So it could be sometimes due to screening error or maybe a temporary condition like a head cold. And it wouldn't be practical to refer every child who didn't pass the screening the first time to a healthcare provider. They'd be overwhelmed. So what do? We screen the child again in 2 weeks. And if the ear passes at that point, the child passed and they're done. If, however, the ear still doesn't pass the screening, then further evaluation is needed. And we expect, especially in the younger groups of birth to 3-year-olds, about 8% of the children won't pass this second screening and will need to have their ears checked by a healthcare provider using tympanometry or pneumatic otoscopy to see if they've got a middle ear condition, maybe an infection that nobody knew about. It's not uncommon that wax blockage or fluid in the middle ear has prevented the screening of the middle ear from being completed. Now, at this point, you'll want to intensify your monitoring of the child's follow-up. Closely consult with the healthcare provider to find out the results of the middle ear evaluation and any treatment that is being provided. You always document the results of that middle ear evaluation. And keep in mind that since the ear hasn't yet passed the screening, we still don't know if the inner ear or the cochlea is functioning properly. Most healthcare providers don't have hearing screening equipment, and therefore they can't complete the screening process on their end. So you'll want to confer with the healthcare provider about when the ear should be considered healthy and ready to be rescreened. After the middle ear evaluation, we conduct a rescreen. And if the child's ear passes, it's complete. And if the ear still doesn't pass, the child should be referred for a pediatric evaluation from a pediatric audiologist. Less than 1% of the children you'll be screening will typically go this far into the protocol, but it's helpful to inform the healthcare providers who are involved in middle ear evaluations that they may need to make a referral to the audiologist should the ear not pass the rescreen after they've been to the healthcare providers. Be sure to support the parent in getting the audiological evaluation completed. Provide the audiologist with all of the screening and follow-up health-related outcomes, and obtain a complete report of the audiologist's evaluation. So that gives you an overview of the complete screening and follow-up protocol. Again, the screening and follow-up process is complete when either the child passes the screening on both ears or the child receives an evaluation from an audiologist and you've gotten the results. Remember, although screening can lead to the identification of the most common types of permanent hearing loss, what you're doing is only a screening. Anytime a parent or a caregiver or a teacher expresses concerns about a child's hearing or language development, referral for an audiological evaluation is warranted. So let's see if you have any other questions here about anything we've talked about so far. Remember our website here, We hope after we're done today, you can go and spend some time looking at the resources that are available here. You can find access to training there if you're needing more, or if you have new staff, refresher training, that's all available there. And then other practical tools for implementing quality screening. Remember, having the device isn't what makes it evidence-based. It's using these devices appropriately that make what you're doing evidence-based. So, spending some time to ensure that you're following these checklists, regardless of which method you're using, is the key to being sure that you're implementing evidence-based practices. So if you have more questions here, is Terry on yet, Gunnar?
He is not. His internet went completely out, it looks like.
Okay. All right. So I will attempt to answer whatever technical questions I can. I'm not the audiologist, Terry is, but I think I can answer a lot of these questions. So the first clarification question is, I'm on the kidshearing.org website. Is this the correct website for the resources you've shown? Yes, it is. It's a part of the infanthearing.org website. So both of those websites are siblings to each other. And you'll find at kidshearing.org, it takes you straight to the early childhood resources. If you want to find the recording for today's webinar, you can find that on infanthearing.org. The next question is, in my experience, the OAE screening does not work with even slight background noise, even from a nearby room. Is that normal? And what suggestions do you have? So, as we mentioned, not all equipment is equally effective in working in some of these natural environments, but most of them do well. It's one of the things that we always encourage people to consider when they're purchasing equipment. Try out the equipment before you pay for it. Take it for a test drive and try it in these different settings. Many devices do work fine with a moderate amount of noise. And so if you have some screeners who are able to use the device in that environment, but not others, that would signal to you that it's not so much the noise of the environment that's problematic, but probably your probe fit. So getting a good snug fit of the probe and looking at the strategies that we have in our resources about how to do that, to pull the ear back, insert the probe, give it a little twist, make sure the cord is attached to the child's clothing so it doesn't pull the probe loose and then let go. All of those things can be really helpful to blocking out the noise from the environment. But I know that can be really frustrating if you have a device that seems ultra sensitive to noise. I would encourage you to try to take your device when you're not trying to screen and play with it a little bit to see if I get a really snug fit on my own ear, and then I create some noise in the environment, does it stop screening, or am I able to do it? So you might want to test it on yourself where you really feel like that is a good snug fit. I can feel the fullness in my ear and I'm not hearing the background noise like I would be if this wasn't in my ear. And then see that would be a really good way to determine whether your piece of equipment is actually overly sensitive. Another question is, I was reviewing the child screening form and I noticed that if they have failed 2 times, they're referred to a healthcare provider. Can't we just refer to an audiologist? Well, you could, but the most common first step is that the child has a middle ear condition that may need to be treated by a healthcare provider. And we want to make sure that that is done so that the child's middle ear condition is addressed. If you refer straight to the audiologist, that audiologist is most likely to refer the child back to the healthcare provider. So you've actually added a step, not eliminated one. Keep in mind that if we follow the protocol this way with the healthcare provider, you're only going to be referring children to audiologists about 1% of the time. And there aren't that many audiologists. So that's why the protocol is sequenced the way that it is. The next question is, doing the OAE, children screening at their comfort zone doesn't work for me because of external noise. I'm unable to have a correct result. So one of the, this also relates to the environmental noise question, and I would suggest another scenario you consider is to try screening during a nap time when there is some control over that external noise, or at least test the equipment under different noise conditions so that you can determine whether it's the equipment or whether perhaps it's your technique. This is when it can be really helpful to have an audiologist come and help you with probe insertion, or by reviewing some of the strategies in the tutorial modules that you can access through the training that's on the website. Here's a question. Is it normal to get more referrals in the wintertime due to underlying illnesses, runny noses, etc.? Yes, it is. Excuse me. It is. We sometimes we have to screen at that time of year, but you are going to have more referrals during that time of year. And that's why we want to have this step, the 2-week wait after the first and the second screening, because that gives some time for those conditions to just change. And a child that may not have passed initially, hopefully will have the cold over with by the time you screen them again. The next question, what should we do if there is evident earwax and the ear is just not clean? Typically, our recommendation is that you can screen a child with earwax. Sometimes it'll actually come out on the end of the probe. You can remove it, clean the probe, and try again, and you may get a passing result. You can believe any passing result. You don't have to rescreen. If the wax is causing what you perceive to be the reason for causing a possible reason for a referring result, then you'd want to just refer that child to a healthcare provider to get the wax removed. It's never recommended that you do any wax removal yourselves. The next question is, what is the pass criteria for OAEs? Is it DP or TE? And our recommendation from our audiology consultants is to use the DP OAE settings on your device. The next question is, how long do ear tips last for OAEs? Well, it depends on what you're asking here. Now, keep in mind that ear tips are only to be used on a single child. They're intended to be disposable, which I know is costly. Now, some people do clean the plastics probe covers. However, we don't recommend that. The probes themselves, unused, will last a long, long time. So, I mean, many, many years. So I wouldn't be too concerned about that if that's what that question is about. How long do we wait after PE tubes are placed and then do a hearing screening? I think you can do it within about 6 weeks, but I again would refer to a healthcare provider or audiologist about that question. That is one of the questions I would have asked Terry to chime in on. So don't take my word for that answer. Check with an audiologist or a healthcare provider, or email me and I'll get you the straight up answer to that question. And you can email us through our website. I think the next question is, which states in the US mandate the screening procedure, pure tone or OAE, in a 3 to 5 year old? I don't have the answer to that question. You would need to look at your individual state recommendations about that. They're always they can be changing. So we'd be reluctant to be the ones to advise on that particular guideline. Let's see. We are at our time limit. So notice in the web chat window that there is a link to our survey that will produce a certificate of attendance today. Complete that, and you should get a certificate emailed to you promptly after you do that. If there are other questions you have that you would like us to address, email us through our website and we'll be happy to respond to you. We really appreciate everybody's time and attention today to trying to implement the highest quality screening for the children in your program. Remember, kidshearing.org is where you'll find all of our resources, including access to training for refresher training or for those needing their first time screening training in the use of pure tone or OAE screening. That is also available at learntoscreen.org. These are redundant websites. The learntoscreen.org is where you will find the training directly. Thank you, everybody. A thank you to our captioner for your services today, to our tech support, and of course to Terry Faust, who was here with us until his internet went down. Thanks, everybody. Oh, and remember, February 9th, is our introductory webinar for folks you might know who would benefit from the introduction to evidence-based hearing screening practices. If you go on infanthearing.org, you'll find that webinar announcement where you can register for it. Again, on infanthearing.org. All right, thanks, everybody.